Hello guys, how are you all? Vanda, Rishi Raj, Namaste. Rishi Raj, Anjana Paul, good evening. Vanilla, good evening, Vanilla. Right, so let us wait for 2 more minutes and then we shall enter into the topics, okay? Meenakshi Chauhan, good evening, Meenakshi. Gopi Raja, Sammy, hello, Sammy. Dr. Benedict, I'm fine, thank you. How are you? Jishi Khan, hi, Jishi Khan. Now, this is a very big name, so can I call you Shabazz? Good evening, Shabazz. Chetan. Hi, Chetan. Ahmad Alpha Keh. Good evening. Insha Khan Vlogs. Hi. Dr. Bendek, it's not my grace, it's God's grace. Gani Naik. Hi. Pujita. Good morning. Pujita, good morning. Good morning. Yeah, but anyways, she is right because when you meet any person for the first time, you tell good morning. This is basically seen in Germany. Right. But anyways, fine. Shubhangi Kaushik, good evening. Manoj Chaudhary, good evening. Good evening, all of you. Ikra Akhtar, hi Ikra. Mohammad Adnan, good evening. So I don't think so that most of you were in the previous sessions, right? I mean, only few of you were in the previous sessions. But anyways, as all of you know, right? Um, Saifullah, thank you so much, Saif. Thank you. So in the previous sessions, guys, we discussed the first part of the upper limb, right? In the first part, we have discussed all these things. So we have discussed all these things. We have discussed the muscles of the pectoral region. Now, where do I find these videos? These videos are already uploaded in the YouTube. You can find them. Okay. Pectoral region we are done. We are done with the back. But now we shall be discussing the remaining. The major part. We shall be focusing on the major part. So previously we have discussed all these things, right? The trapezius, the latissimus dorsi, all these things, and even I made you to do the questions also. So today also we shall be discussing the remaining topics, and we shall try to complete the complete upper limb along with the arteries. Today's session, guys, I don't know how the previous sessions were, but today's session is going to be very, very high and so interesting. So I want all of you to do two things. First thing is that you have to be with me till the end of the session, right? And I promise you that I'll teach you everything, right? You even need not to revise them. So I'll teach you super clearly. And second important thing is that I want all of you to make notes. And whenever I tell you to stop making the notes, you have to stop it, right? Thank you, Dr. Ventek. Thank you so much. So shall we start, guys? Shall we start discussing the new part now? Right? And Dr. Bendik, you did not join yesterday's session. May I know why? Yesterday was the surgery session, right? I wanted you to join all these sessions. Shubhangi Kaushik, yes, fine. So everyone has given a green signal. Now let us start. And after discussing this, I even have a lot of questions for you which were previously asked. For example, like you can see this. This is the recent pattern question which was asked in 2018-19, but whatever it is, we will discuss all the different kinds of questions as well, right? So let me make right. So Dr. Bendik, I even want you to attend the remaining sessions also. He was in London, right? Screen is not clear. I did not write anything on the screen yet. Okay, fine. So look here, guys. Look here. All of you pay attention now. I want you to focus here. So let me first of all classify it. What are the things we have discussed, and then we shall enter into the topic, right? So we have discussed the muscles. I hope everyone, my voice is audible to everyone. At the same time, whatever I'm writing is visible to everyone, right? So in the muscles, we have discussed muscles of the back. We have discussed muscles of the pectoral region. Okay, but today we shall be discussing some more important topics. For example, we shall be discussing the muscles of the scapular region. Okay, it is a blur. Is it blur, guys? It's clear. So I think Shabaz, I want you to off the Wi-Fi and again once again see whatever is there with you regarding the connection and all. Okay, so I want you to switch to 1080p. Okay, so scapular region, and after that, yes, fine. Okay, all of you now concentrate. We shall be discussing regarding the scapular region. We shall be discussing the muscles of arm, forearm, as well as hand. You will wonder, guys, I know most of you know all the nerve injuries, most of you know everything, but I'm gonna teach you few important things which only few doctors might know. Okay, so we shall discuss everything in related with the clinical points. So let's get started now. Now I don't want anyone to comment. Let's get started. Okay, fine. So coming to the scapular region. And by the way, I'll upload these notes onto the Telegram group. Don't worry. Coming to the scapular region, guys, one very important thing I want to tell you is that this is your scapula. Okay, so what is this bone? This bone which you can see is your scapula. Now in this scapula bone, there are few important things to understand. Okay, so all the muscles which are attached to the scapula, we are about to learn now. Now, for example, when you go to any hospital or when you attend your friend's house, what are they going to tell? They're gonna tap on your scapula, right? So they're gonna tap like this and they'll tell you, come on, sit down, right? So please sit. So for example, even if you visit a doctor's room, even doctor is gonna tap, nothing is gonna happen. Please sit down, right? So what are the muscles here? What are the muscles? The first muscle in the scapular region is the deltoid muscle. The deltoid muscle. I'll draw all of this. Don't worry. I will also go for the clinical parts. Don't worry. Second important one. So when you attend a doctor room, he will make you to sit. Right? So what does S stand for? S stands for supraspinatus. Simple thing, guys. Simple thing. This is the scapula. Okay. This is your humerus bone. All of you know. Scapula fixes to the humerus. Okay. Now, after one scapula fixes to the humerus, here you have got a muscle. Exactly, my left hand represents a muscle. It is like this actually. This muscle is called as deltoid muscle. All of you know that. Second important muscle. If this is a scapula, this is called as the spine of the scapula. Now, above the spine, I have got some space. Below the spine, I have got some space. So what I will do is that I will put a muscle above the spine. If I put a muscle above the spine, it is called supraspinatus. If I put a muscle below the spine, it is called infraspinatus, right? So one will be supraspinatus and the other one will be infraspinatus. Okay. Next important thing is that if you look very clearly, guys, if this is the attachment, for example, okay, from the scapula till the humerus, you have got two major muscles. Now this one is a muscle and these three fingers together are also a muscle. Now this single muscle here is called teres minor. So if I combine like this becomes a major one. So this is called teres major. Okay, so you have got fourth important thing, you have got teres minor. And yes, Osama is perfect. He already told about rotator cuff. I'll be teaching you in a minute about that. Teres major. And finally look here, guys. This is the scapula, right? So this is the scapula which you can see like this. It means this is the dorsal side of the scapula, whereas this is called as the ventral side of the scapula. So ventral side of the scapula, whatever is there, this is called as subscapularis because it is below the scapula, isn't it? If I put the scapula like this, the muscle is below the scapula, so it is called subscapularis. This is called subscapularis. So very, very easy, guys. Deltoid muscle, supraspinatus, infraspinatus, teres major, teres minor, and subscapularis. So these are very simple muscles. Okay. So I hope you understood all of this. What is rotator cuff? I'll tell you in a minute. But in the previous year's exams, I think it is in June 2007 FMG exam. What they have asked is, they have asked regarding the deltoid muscle. You might think they might have asked maybe function, maybe the nerve innervation. No, they did not ask nothing. What they have asked you about deltoid muscle is that, look here very carefully. If you are a first year student or a second year student, you have to know the origins and insertions. But trust me, for your exam point of view, I mean for the next exam which is coming, no one is going to ask you origins and insertions. Okay. But if you are a basic student, you just have to understand it. Now look here, all of you. This is the scapula which we have. Okay. And this is called as the spine of the scapula. Isn't it? This is called as the spine of the scapula, like this. This is called as the spine of the scapula. And all of you know that here we have got our clavicle. This is our clavicle. What is this? Clavicle. And here I've got our humerus bone. So this bone here is our humerus bone. So all of you know this picture. Okay. So I've drawn the spine of the scapula like this. Okay. And this is called as the glenoid cavity. So this is the glenoid cavity where the head of the humerus is fixing. So I'm going fastly because I don't want to discuss the bony prominences now. It's not that important. Shubhangi, right? That is glenoid. Now there is a muscle, guys. Listen, all of you listen. There is a muscle which starts from half of acromion, half of clavicle, right? So this muscle is starting from the the lateral half of the clavicle. This muscle also starts from the spine of the scapula. You see, this muscle is also starting from the spine of the scapula. Not only that, this muscle also starts from the acromion process. Like this. Okay. So what are the places this muscle is starting? Lateral half of clavicle. Okay. Next, spine of the scapula. At the same time, acromion process. Okay. Yes, BTS is telling that it is coming from the inferior side. Yes, I have drawn the red line on the inferior side of the scapula, inferior side of the spine, and inferior side of the acromion process. Okay. So from all this muscle originates like this, and look here, this muscle inserts to the humerus bone. Which part of the humerus bone? On the humerus bone here, you have got a tuberosity here. This tuberosity is called as deltoid tuberosity. Okay. So this muscle attaches to the deltoid tuberosity here. So this is the muscle that is attaching to the deltoid tuberosity. Deltoid tuberosity. And obviously this muscle is called as the deltoid muscle. All of you know, right? Now, I'll discuss what is the MCQ at the end after discussing all the muscles. Now, deltoid muscle is done. So what have you learned through the picture? You have learned that these are the origins of the muscles and this is called as the insertion of the muscle. Clear, all of you? All of you are clear till now? Yeah, before I draw the next picture, I want your comments telling whether if you are clear or no. Right. Coming to the next muscle. Another muscle I told you, what was that? There is some part of the muscle above. This muscle is called as supraspinatus muscle, right? And there is some part of the muscle below the spine. This is called as infraspinatus muscle. One is supraspinatus, one is infraspinatus. And another muscle, look here, all of you look carefully. There is another muscle that comes all the way and attaches to the humerus like this. Okay, just beneath that there is another muscle which comes all the way and attaches to the humerus in this way. Now I have discussed these two things very clearly, guys. Previously I have been discussing these things, that for example, if this is your humerus bone has got two lips, right? Your humerus bone, in the center it has got two lips like this, right? If you can see here, I'm not sure it might be visible to you. Here you have got two lips. Okay, this one is called as the lateral lip, this is called as the medial lip. This is called as the lateral lip of, what is this? Lateral lip of, what do we call it as? Gani Naik, major and minor muscle, excellent Gani. Osama Sheikh, you're also right. Very good, Sanyasi Pandit, excellent. So this one here is called as bicipital groove. This bicipital groove is actually like this, guys. So let me show it to you. This is how the bicipital groove is. This bicipital groove, the center one is the bicipital groove. Bicipital groove has got a lateral lip, it has got a medial lip. Okay, I've told you this before, right? Now, what is the muscle that is attached to the lateral lip? Let us say this is lateral lip, and let us say this is the medial lip. Okay, so what is the muscle attached to the lateral lip and medial lip? Obviously major muscles, whatever it might be, they are called major muscles. There are two major muscles. Now what are those two major muscles? Anyone? Very good, Jamil Ahmed, very good. Shabazz, nice. Dr. Benedict, perfect. Right, so to the medial lip, teres major is attached. Teres major is attached to the medial lip. So what is the other major? We have got two majors, teres major and pectoralis major. So pectoralis major is attached. Pectoralis major as well as teres major. Sondashi, you are right. Sondashi, Kruti, you are right. I'm really happy, guys, because all of you are answering right answers. I'm really happy with this. Thank you so much. Right. So this muscle which I have drawn here, this is called as teres minor muscle, and this muscle is called as teres major muscle, which is attached to the medial lip. Okay. Okay, sir, fine. So why are you teaching this? Why am I teaching you this is, there is a very important clinical point which you need to know. What is this clinical point is that, keep in mind three muscles. One is called supraspinatus muscle, another one is called as infraspinatus muscle, and another one is called as teres minor muscle. Supraspinatus, infraspinatus, teres minor, all of them, where are they inserted? Look here. Here we have got two tuberosities. So this greater one which you can see here, this one is called as greater tuberosity, and this is called as lesser tuberosity. So all these muscles are attached, three muscles are attached to the greater tuberosity like this. Three are attached to the greater tuberosity. Okay, so look here, all these muscles, they come like this and attach to the greater tuberosity in this way. All of them are attached to the greater tuberosity. Clear, everyone? Then what about lesser tuberosity? Which muscle is attached to the lesser tuberosity? Lesser tuberosity is small, it is minor. So obviously, which muscle will be attached? Anyone? Anyone? Excellent, MS. Subscapularis. So when I'll turn the picture back, I'll tell you that. Okay. So for now, you need to know these four muscles. Excellent. Excellent, Sondashi. For now, you need to know these two muscles. So supraspinatus, infraspinatus, teres minor, teres major. Now, out of all these muscles, how many muscles here are rotator cuff muscles? How many muscles here are rotator cuff muscles? What is rotator cuff? I'll tell you. Look here. Supraspinatus, infraspinatus, and teres minor. Okay, supraspinatus, infraspinatus, teres minor, and the fourth muscle is subscapularis. So all these three muscles, they together, all these three muscles together, they are attached to the greater trochanter, whereas subscapularis is attached to the lesser trochanter. Okay, but what are rotator cuff muscles? All these four muscles which I have drawn here, they are called as rotator cuff muscles. Why are you calling it as rotator cuff? Because all these muscles are like a cuff. Okay, if this is the thing, all these muscles are located in the form of a cuff like this. Okay, that is why it is called rotator cuff muscles, which are giving strength, which are giving support to the humerus. Okay, which are giving strength and support to the humerus. All of you are clear so far, guys? Let us do this session fastly. Are all of you clear with this? Yeah. Right. Very good, very good, very good, and very good. So this is a very important question, very, very important question. What are the muscles that come under rotator cuff? You will answer all of them. But one important thing is that instead of teres minor, they will put it as teres major. That is a blunder mistake. Teres major is not a rotator cuff muscle. Teres minor is a rotator cuff muscle. Okay. And if I ask you, out of all these four rotator cuff muscles, which is the most commonly injured muscle? Out of all this, which is the most commonly injured muscle? Right? Which is always on the top is the most commonly injured muscle. What is the muscle that is always on the top? What is the muscle here which is always on the top here? Supraspinatus. So supraspinatus muscle is the most common injured rotator cuff muscle. Very, very, very important. Kabsar Ahmad, physiotherapist, Jamil Ahmad, everyone excellent guys. Syed Alia, excellent. I think you guys are really very perfect with the basics. I'm really happy for that. What is the function? Now Jamil Ahmad asked me the function. I'll tell you the function. First I'll tell you the nerve innervation and then I'll tell you the function. Okay. So till here everyone understood. Till here everyone understood, right? Now look here. Coming to the nerve innervation. Coming to the nerve innervation. Supraspinatus, infraspinatus, teres minor and subscapularis. All of you should remember this one mnemonic, right? Remember it as SALU. You know, SALU in different languages, it means differently. Okay. Now I don't want to go in depth of each language. Just remember it as SALU. Hey, SALU. Okay. SALU. Okay. Remember it like that. Fine. Now, look here. Supraspinatus muscle supplied by which nerve? Supraspinatus nerve. Okay. Supraspinatus muscle is supplied by supraspinatus nerve. You also call it as suprascapular nerve because it is above the scapula. So S stand for suprascapular nerve. Suprascapular nerve. Okay. Now, what is infraspinatus supplied by, guys? What are homologous muscles? For example, supraspinatus, infraspinatus. Both of them are located above and below the spine. So if above the spine is supplied by one nerve, the same nerve supplies the muscle below the spine also. So it means suprascapular nerve supplies the infraspinatus muscle. Second thing, what does A stand for? A stands for axillary nerve. Very, 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 very important, guys. A stands for axillary nerve. Very important. Okay. Next, coming to the subscapularis. Coming to the subscapularis, but before that, we even have to write another muscle here. What is this? Teres minor, teres major. Coming to subscapularis. Now, not subscapularis. Here it is subscapularis. So what is teres major supplied by? After S, we have got A. After A, we have got L. What is L stands for? L stands for lower subscapularis nerve. It stands for lower subscapularis nerve. So when I tell lower subscapularis nerve, automatically there will be upper subscapularis nerve. Upper subscapularis nerve. This is the nerve innervation, guys. See, it might be a little tricky or difficult for you, but I'm telling you, this is very, very easy. Okay, so remember it as A Salu. Now, what does S stand for? Suprascapular nerve. Again, S stands for suprascapular, A stands for axillary, lower subscapularis and upper subscapularis. Okay, clear everyone? Right, guys. All of you now, don't write anything, don't make any notes, just pay attention. Just pay attention. Look here, all of you look here now. Just pay attention. Now I have prepared something for you. I've prepared something for you. Look here. All of you look here now. When I'm bending it like this, can you see a blue color ribbon over here? Right? I hope you can see. Now this ribbon is starting from the suprascapular region and it is going all the way and it is attaching to the greater tuberosity. Because I told you in the starting, suprascapular muscle attaches to the greater tuberosity. See, from the suprascapular fossa, this muscle goes all the way and attaches to where? The greater tuberosity, right? Now, if this muscle is contracting, what will happen? Let me show it to you on other scapula here. Look here. This is a muscle like this. This is a muscle like this, right? From here it is going all the way. If I'm pulling this muscle, towards the scapula, look here what will happen. If I'm pulling this, my humerus is going away. My humerus is moving laterally, isn't it? If I'm pulling it, my humerus is going laterally. Can you all relate with that? You understood the mechanism here? So very good. So can I tell supraspinatus? Supraspinatus is responsible for abduction. Again, for all the new viewers, I'm telling you one thing. Remember it as lab. Remember it as bad. Okay. L stands for moving laterally. So it is called abduction. B stands for moving towards the body. This is called adduction. Okay. Keep that thing in mind. Akash Sharma. Perfect, Akash. Gani Naik. You all are right. Before me telling the answer itself, you guys have been commenting here. I'm really, really happy. Right? See, guys, you are commenting this, which means you know the answers. It means you are on the safe side. You know why? Because these questions are again and again asked for your exam. Okay? You are 110%, you are on the safe side. Now, there is another muscle. Look here. There is something called medial rotation and lateral rotation. Look here. This is the thing. If I am, look at the lower surface here. If I am rotating like this, this is called lateral rotation. If I am rotating like this is called medial rotation. Okay. See, if I am rotating like this is called lateral rotation. If I am rotating like this is called medial rotation. Fine. Now, all of you should concentrate here. Look here. You can see this muscle. Now, can anyone name me what is this muscle here? It is below the spine. Anyone? Come on, be fast. We are still hanging on with the same topic. Come on. No. Infraspinatus. Below the spine, it is infraspinatus. Osama Sheikh, excellent. Kruti, it is not teres minor. It is located below the spine. So, infraspinatus Kruti. Meenakshi, perfect. Cyanide, perfect. Right. For example, if this infraspinatus muscle is contracting, then what will happen? My humerus, look at the lower portion. My humerus is moving laterally like this. Okay. Opposite to that, this muscle which you can see here, this is called subscapularis. If I am pulling this side, look at the lower end. The humerus is moving medially like this. Isn't it? it is rotating medially. But if this contracted, my humerus rotated laterally. So can I tell that infraspinatus muscle is responsible for lateral rotation of arm? Lateral rotation of arm. Now don't confuse, arm means not this total arm. Arm is only this. This is forehand. This is arm. Okay. So lateral rotation of arm. And subscapularis is responsible for medial rotation. Medial rotation of arm. Clear, everyone? Are my explanations clear regarding these actions, guys? Are my explanations clear? Roy, you're finally here. Thank you. Osama. Okay, fine. Excellent, guys. So, why are you telling this? Why are you telling this? Are there any questions which can be framed? Yes. They will ask you, patient's lateral rotation is hampered. There is no lateral rotation of arm. Which nerve is damaged? Lateral rotation is responsible by infraspinatus muscle, and infraspinatus muscle is supplied by suprascapular nerve. This is how they're gonna relate it. Okay. If you have a doubt, if you really have a doubt, let me do this question for you. Look here, all of you. All of you do this question. A 53-year-old man presents to the clinic with a 6-month history of shoulder pain. He is having shoulder pain, fine. Over the weekend, he strained his shoulder. See, he has strained his shoulder. Always remember, whenever you are straining the shoulder a lot, the most common area which will be under injury will be your rotator cuff muscles. During a pickup basketball game, and reports an acute exacerbation of his pain. On examination, he complains of pain to palpation just below the acromion. You suspect there is a tear in his supraspinatus muscle. So again, supraspinatus, I'm contracting it. When I'm pulling it my side, the arm will be going to the other side, isn't it? So this is already restricted. Supraspinatus, when I'm pulling it, the arm laterally it goes. It goes what? Laterally. Okay. So now you tell me, what will be the answer here? Supraspinatus, what is the action? Roy, you're perfect, guy. You already answered. I want answers from everyone. Sanyasi Pandit, excellent. Osama Sheikh, excellent, and excellent. So, initiation of abduction. Perfect, guys. Love you all. Perfect. Superb. Nice. You know, there was a question which was asked previously. I have already told you, most common injured muscle among the rotator cuff is, which is on the top, that is injured. Which is on the top is supraspinatus, so that is injured. So now you tell me this question. Now, this question, guys, this was asked in August 2020, not 2020, I think. Yes, it was August 2020 FMG. That was the time when they started setting the clinical pattern of the paper. That time they asked this question. Most common injured muscle in rotator cuff. Come on. Most common injured muscle in rotator cuff. Dr. Benedict has already come with the answer. Pujita Paidi. Yes, you are right. It is abduction. It was the previous question. Excellent. All of you are coming with your answers, guys. Perfect. Excellent. Now look at another question. This one. All of the muscles of rotator cuff except Agia, you are right. Kavsar Ahmad, Nandini Shiva, Saif Doctor, you are right. See, all of you are answering wrong. You know why? Because I just got the topic. But if such question comes in the exam, you know, answer will be one, either A or B. See, that is the place where you get filtered out. So I'm telling you, always remember that. Major is not there. Okay? Major is not there. Very good. Very good, guys. Very good and very good and very good. So I think, guys, I think these are the things which they ask. But I'll give you one last question. One last question. Okay. And then we shall move to the muscles of the arm. Most of you told the muscles of arm and forearm, they are really very difficult to understand. So maximum I tried myself to, make it easy. But finally, whatever it is, we shall do one last question from the scapular region and then we shall move further. Okay. What is that one last question is, sometimes they will give you this thing. You know what? They will give you this kind of question. Now, where has this been now? Right. Give me a second. Yes, I got it. Just give me a second, guys. Yes, sometimes they're going to give you these things. Now, what are these things? What is this scan called? This is called as an MRI scan. All of you know this. This is called as an MRI scan. Khan Amin, good evening, Khan. Good evening. Now, this is called as an MRI scan. Look here very carefully, guys. It is not very difficult, very easy, very, very easy. Look here. See, you see a muscle like this. This is coming all the way and it is inserting like this. See? Right? So this entire group of muscles which I've drawn, right? So this bulk of muscles which I've drawn, these are called as rotator cuff muscles. Out of this thin muscle, whatever is there, what is this thin muscle name? Supraspinatus. Supraspinatus, because I have already shown you here, right? Supraspinatus. Supraspinatus muscle. Now, same rule, guys, same rule. Previously, I've told you, in an MRI scan, if you wanted to look at anything which is abnormal or there is a tear in the ligament, that will appear super white, bright white in color. That is called, what is that called? Hyper intense lesion. Hyper intensity, the brightness will be more. See, this is normal. This is normal. Just compare this picture. Compare this picture with the next picture over here. Look at this picture. It is completely white here, which means there is a tear of which muscle? There is a tear of which muscle, guys? Come on. There is a tear of which muscle? Nandini Shiva, Divesh Mishra, good evening Divesh. Nandini Mishra, I want you to answer. Osama Sheikh, Roy the Old Gamer, Cyanide. Cyanide is answering excellent. Ahmad, excellent. Agya, Savlani, Supra, excellent guys. So this muscle is your supraspinatus. Supraspinatus. Abdullah Qureshi, it is not deltoid. Deltoid is here, okay? Abdullah, deltoid is here. Right. A small test for you. Now you will tell me, is it normal or abnormal? I mean, you're not telling me it is normal or abnormal, but just tell me, there is a tear or there is no tear. Is this MRI normal or there is a tear? Tear in the rotator cuff or no? Sangam Yadav, excellent. Excellent, Dr. Benedict. Meenakshi, there is tear. You can see Meenakshi here, the lesion is hyper intense, just located above the humerus. Abnormal. Osama Sheikh, you're perfect. It is abnormal. Very good, Osama. Sammy, excellent. Osama, The patient will cry. You no need not to cry here. Right. Roy has given a very good explanation. There is hyperintense image, whitish tendon part. Excellent, Roy. Excellent. Right. So I'm telling you, I'm promising you, if they ask you any question from the scapular region, the questions will be from this only, guys. Okay. The questions will be from this only. Fine. Right. Fine. So I think this might be a female patient. That is why Osama is so much of emotional. Right. Now let us go for the arm region muscles. Let us go for the arm region muscles. Now in the arm also, there are two types of muscles. Okay. Right, guys. Anyways, I want all of you to share this live lecture link to your friends as well, so that even they will watch the videos and all. So this would be a great support for me, at the same time for you as well. Okay. Right. So arm muscles are two types. Now, whatever muscles which you can see here, this is called as the anterior compartment muscles. Whatever muscles which you can see here, this is called as the posterior compartment muscles. So this is anterior compartment and this is posterior compartment muscles. Okay. So arm has got two compartments. One is called as the anterior compartment. Another one is called as the posterior compartment. All of you from today onwards, you have to remember a rule. What is that rule? This is the anatomical position of the body. Whatever you can see directly onto me, all those are flexors. All the muscles here are flexors. All the muscles here are flexors. Here also all the muscles are flexors. But when I turn back, all these muscles here, right? All of them are extensors. Flexors, wherever flexors are there, they are the anterior compartment here, and wherever the extensors are there, they are the posterior compartment. Okay. So anterior compartment is also called as flexor compartment. Posterior compartment is also called as extensor compartment. Right. Anterior compartment is called as, yes, Madhavan Kutti, human makes mistake, even I make a lot of mistakes. Right. So anterior compartment is called as flexor compartment, posterior is called as extensor compartment. Now, how do you remember the flexor compartments? How do you remember the flexor compartments, sir? Remember it as BBC. Now, not at all a bad word here. My intention is not to teach a bad word. BBC means British Broadcasting Corporation. You know it, right? Right. So, BBC, hi MedBooster, welcome. Welcome for the session. BBC. Now, what does BBC stand for? First muscle, B for biceps. B for biceps. Biceps means, don't just tell it as biceps. Biceps brachii. Okay. Another B for brachioradialis. Brachioradialis. And C stands for coracobrachialis. Coracobrachialis. Sir, should we know origins and insertions here? No, not needed. Coracobrachialis, from the coracoid process to the brachium. Coracobrachialis. Brachioradialis, from the brachium to the radial side of the bone. Brachioradialis. Right? Very easy. So BBC. Clear? Let me also write the posterior compartment muscles and then we shall go. Posterior compartment extensors has got a muscle called as triceps. Triceps means three heads. Okay. Remember it as LML. What does LML stand for? L stands for lateral head. Lateral head. M stands for medial head. And L stands for long head. L stands for long head. Rajesh Gaud is already with the answers here. Excellent, excellent, and excellent. Right. Now, sir, you're telling me biceps. You told me triceps. Seps means heads. There are three heads you told me. Then biceps brachii has got It should have two heads then. Then why you didn't write? I forgot. Now biceps has got two heads. Short head, another one is long head. Short head and long head. Okay? Short head and long head. Next important thing. Next important thing is that remember this. All of you remember this. Posteriorly, the entire nerve which is supplying the posterior compartment is radial nerve. In the arm, in the forearm, the entire posterior compartment is supplied by radial nerve. So if I ask you any muscle of the forearm region, for example, let us say extensor carpi radialis. It is a extensor muscle, I mean the posterior compartment. So the nerve will be radial nerve. Any nerve in the posterior compartment of arm, forearm, radial nerve. Okay. Now, when it comes to Hurriya Sadaf, excellent, it is radial nerve. When it comes to the anterior region, the nerve is musculocutaneous nerve. Musculocutaneous nerve. And here it would be radial nerve. Here it would be radial nerve. Is everyone clear with this? Yeah? Now, before you put your comments, whether you are clear or not, I'll draw a simple picture. I'll draw a simple picture. Right. Look here now. All of you look here. All of you should concentrate here no matter what. All of you should concentrate here. Come on. All of you. Now, I told you that this is called as the glenoid cavity. This glenoid cavity has got two parts. Above the glenoid cavity, this small notch which you can see here, this is called as supraglenoid tubercle and this is called as infraglenoid tubercle. Okay. So it means, see, this is called as a supraglenoid tubercle. This is called as the infraglenoid tubercle. Then what is this process, sir? This is called as coracoid process. Coracoid process of the scapula. Okay. Coracoid process of the scapula. Now look here. What did I tell you? I told you that biceps, I don't want anyone to write here. Just concentrate whatever I'm teaching. This is very important. Biceps has got two parts. Biceps has got two parts. Okay. One is called as the short head of biceps. Another one is called as the long head of biceps. Remember one thing. Short head of biceps. Short head of biceps. It starts from the coracoid process. It means from the coracoid process, the short head of biceps will come like this. Okay. From the coracoid process. Then where will the long head of biceps come, sir? Longer head of biceps will start from the supraglenoid tubercle. It means from here. Okay. Everyone clear now? Right. Now look here. So you are telling me short head starts from coracoid process, long head starts from supraglenoid tubercle. Let me write it down. Supraglenoid tubercle. Okay, fine. Now where are they going to end? See, all this entire biceps muscle will come like this, and biceps has got a tendon which you call it as biceps tendon that all the way comes and inserts to the radial tuberosity. That inserts to the radial tuberosity. So this is your entire muscle, biceps muscle. What is this? This is called as your biceps brachii muscle. Biceps brachii. Sir, what is the nerve innervation of biceps brachii? Anyone? Be fast. Come on. Musculocutaneous, excellent, excellent. Musculocutaneous nerve. Perfect, perfect, perfect. Fine. So this is very simple to learn. Why are you stressing on these points a lot? The reason is that, guys, look here. I'll show you why am I stressing it. 2018 and 19, they have asked you this question. They have asked you this question. Which of the following insertion is shown in the muscle? First of all, what is this muscle here? What is this muscle here, guys? This muscle here is which one? What is this muscle? Excellent, excellent, excellent. All of you, excellent. Dr. Munia, excellent. It is right answer. Osama Sheikh, excellent. Aditya Raj, perfect. All of you, perfect. This is biceps muscle. So where is biceps muscle inserting? Biceps muscle is inserting to the radial tuberosity. He asked here, what is the insertion of the muscle? Insertion. The insertion is radial tuberosity. Clear? Right. Very good. All of you, very good. Let me also tell you another clinical point. Another clinical point. Another clinical. Agya. Excellent. Let me tell you another clinical point that biceps muscle has got two parts. Okay. If this is the biceps muscle, it has got two parts. Okay. This part here is called as the distal region. This is called as the proximal region. This is what? The distal region. This is called as the proximal region. For example, if in the proximal region, if the tendon of the biceps in the proximal region, if there is a tear, what will happen? Will the muscle stay here? No, the muscle is pulled downwards. Because I cut it here, the muscle is pulled downwards. Same way, if I cut it on the bottom, the muscle is pulled upwards. Clear? All of you now pay attention to what I'm writing here. If there is proximal biceps tendon rupture, biceps tendon rupture, proximally, not distally, proximal biceps tendon rupture, you look here now, this is how the muscle looks. So patient was having a rupture at this point, the muscle moved downward. Now this type of muscle is called as Popoy's deformity. Popoy muscle, you know, Popoy the sailor man. Right, that is called as Popoy's muscle. Yeah, all of you are right. Excellent, cyanide, excellent. Dr. Benedict, perfect. This type is called as Popoy muscle deformity or Popoy deltoid deformity. Popoy deltoid deformity. And that happens where? That happens to the proximal biceps muscle. The proximal biceps muscle. Yeah, Sanyasi, wo palak wala. Yeah, that's spinach. Divesh Mishra, I know Hindi, but you know, you guys will laugh if I start speaking in Hindi. Right. So, okay, Divesh, for you, I'll be teaching it. Triceps. Triceps matlab teen sir. Teen sir is called sir matlab we call it as in Hindi, you know. That is the reason why I told you my Hindi is really, really poor. Yes. Triceps teen sir. Okay. Three heads. Three heads. I told you we have got long head. Zainab army. Yes. I know definitely I'll teach in English because you will send your army to me now. Medial head. We have also called as lateral head. Okay. I told you this. Clear now? Look here. All of you look here. Everyone now pay attention. Don't write anything. All of you look. All of you look. Now, I have drawn something important here. All of you know this. This is supraglenoid tubercle. This is infraglenoid tubercle. Sir, why are you discussing supraglenoid? I won't discuss supraglenoid because supraglenoid is already occupied by long head of biceps. It is occupied by long head of biceps. Then what about infraglenoid, sir? Infraglenoid tubercle is occupied by long head of triceps. Clear? It is occupied by long head of triceps. Very easy to know. Long head of biceps is above, long head of triceps is below. Clear? Clear? Fine. Next, what is this pink color line which you have drawn? This pink color line which you have drawn is called as intertubercular sulcus, right? See, this is the one, intertubercular groove or intertubercular sulcus, okay? This is the one. So, above the sulcus, below the sulcus. So, now look here. Medial head starts from above the sulcus, whereas lateral head starts from below the intertubercular sulcus. Simple. Finish. We are done with triceps also. Most of the students will be confused at the biceps and triceps only, guys. Okay, most of them are confused here. So simple thing, heads are always to the tubercles. Upper one is for biceps, lower one is for triceps. Above the sulcus for medial head, below the sulcus is for lateral head. That is why I told you to remember LML. Remember this LML and you will answer all these questions. Now, what is the nerve innervation for triceps? Anyone? Come on, come on, come on. Osama, perfect. Benedict answered first. Osama, Imran. Imran, excellent, Imran. Roy, excellent, Roy. Sanyasi Pandit. Sanyasi Pandit, the answer is not R. It is not R, it is radial. Okay. Dr. Munia, excellent. Roy, excellent. Excellent, all of you. Agya, perfect. So, this is all the important points, guys. So we have discussed regarding the arm region, you know flexors, you know extensors, you know nerve innervation here, you know nerve innervation here, origins and insertions. You should know only about two muscles, biceps and triceps. So far they have asked only those muscles, and again they will ask you only those muscles. Don't worry about that. Regarding biceps, I told you porpoise deformity. Okay, clear, cool. Now look here. BTS, I will teach you this when I will teach you brachial plexus. Okay, now look here very carefully. Clinical question, very very important clinical question. Clinical question is that, let me draw this thing. Now I know this picture is absolutely right. Now I know this is the worst picture, but still very good. Dr. Benedict already told me a person is sleeping like this. Okay, now why a person is sleeping like this? Why a person is sleeping like this? Because he wanted to show us few important things. What are those few important things? He is telling that look here, this muscle is called as pectoralis major muscle. This is called as pectoralis major. And what is this called? This area is called as axilla. What is this called? See, this area is called as axilla. This is called as axilla. And finally, all of you look here. Backside, what is this muscle we have? I have drawn it last time. There is a muscle that is coming all the way and it is attaching to the bicipital groove. What is this muscle that is coming all the way and attaching to the bicipital groove? Yes. Revanth Reddy, excellent. Latissimus dorsi, perfect, Revanth. So there is a small portion of muscle. This is latissimus dorsi. Latissimus dorsi. So I think Sanyasi, Dr. Bendick, they're gym guys. They're telling it as lats. So what I'm trying to tell you is that one side I have got, look here very carefully, very careful. One side I have got base of axilla. Other side I have got the lateral border of pectoralis major, lateral border of pectoralis major, and on the other side, I have got medial border or medial border of latissimus dorsi. What are the three things? Base of axilla, lateral border of pectoralis major, and medial border of latissimus dorsi. Three of them together formed a triangle, and this triangle is called as the safe triangle. Why? Because whenever you wanted to drain anything which is there in the chest, right? To drain the chest, if there is any kind of pus within the lungs, in a patient with pneumonia, right? In a patient with, all of you look here, in a patient with pneumonia, you're right, safety triangle, okay? Any kind of pus which is there within the lungs, to drain that pus, or if patient is having excess amount of fluid, right, hydropneumothorax, so even in that case also you put a chest tube here and you drain it, okay? So if someone asks you what is the safest triangle to put chest drain tube, that is this triangle here. Very, very, very important, guys, very important for chest tube insertion. So this is your pectoralis major muscle, and this part is called as your safety triangle. Safety triangle, okay? This is called as safety triangle. Dr. Benedict is saying because of pleural effusion. Very good, Roy, excellent, Roy. Roy is telling that if this is the rib, we pass the needle through superior surface of the rib. We don't pass through inferior because we have a nerve, we have an artery, we have a vein. So if we pass, we can damage them. But superior surface of the rib, we don't have anything. Okay, Roy, you are excellent, Roy. Perfect. You're right. So we are done with the discussion of arm. Now, let us enter into the discussion of forearm. Forearm. Please raise your hands, guys. How many of you are finding it difficult with the forearm muscles? How many of you? How many of you are finding it difficult with forearm muscles? Now, be fast. Be fast. Roy, I don't think so it would be difficult for you. Sanyasi Pandit, I don't think so. Even you, Osama Sheikh, I don't think so. Even it would be difficult for you, Dr. Benedict. You all are kidding. Right. Anjana Paul, no. This is all lies. Right. Okay, fine. So I want all of you to pay utmost attention. Utmost attention. I'm going to teach you the muscles of the forearm, and we shall discuss the clinical points also. Very interesting clinical points. Okay. Forearm. Forearm is of two types. No, there is only one forearm. Forearm is having two compartments. This is the anterior compartment. This is the posterior compartment. So we have got anterior compartment. We have got posterior compartment. I have already told you all the muscles of anterior compartment are flexors everywhere. All the muscles of the posterior compartment are extensors. So these are flexors. These are extensors. These are extensors. Right? Now, flexors and extensors are there. Now, within the flexors, all of you touch this part. This is, you can very easily palpate the bones, right? You can very easily feel the bones. But touch this part, it is little bit thick. Why? Because in the forearm, on the anterior side, we have got two groups, superficial and deep. That is the reason why here we have got heavy bulk of muscles. Okay, within the anterior group, we have got superficial muscles. We have also got deep muscles, superficial and deep muscles. Till here, all of you are clear. Next important thing, I will write down the names of the muscles, guys. Don't worry. Or else what we shall do is that we shall just put up a box here. Why don't we put up a box, and as I will be discussing each and every muscle, I will write down all of them. As I will be discussing each and every muscle, I will write down all of them, right? So now all of you should concentrate here. Right. Now, this is the humerus bone, you know. Okay. Then this is the radius bone. This is the ulna bone. Radius and ulna. On the ulna bone, you have got a triangular shaped process on the ulna bone. This is called as coronoid process, not coracoid process. This is coronoid process. Coronoid process. Coronoid process of ulna. Okay. Coronoid process of ulna. Next important thing you need to know is that, for example, if this is the arm, this is called as a medial epicondyle. This is called as a lateral epicondyle. This is medial epicondyle. This is lateral epicondyle. Okay. Now, medial epicondyle, the tubercle of medial epicondyle is prominent. That is the reason why this is most commonly fractured. Okay. So, medial and lateral epicondyle. All the muscles of your forearm in the anterior compartment, all of them, they start originating from the medial epicondyle. Okay. So, again I'm telling you, here you have got medial epicondyle, right? All the muscles, they start here and they dive into the forearm like this. Look, they are diving into the forearm like this. So if I ask you, all the flexors of the forearm, they are starting from which epicondyle? Medial epicondyle. Can I call medial epicondyle as common flexor origin because all the flexors are originating here? Exactly opposite to that, I have got lateral epicondyle here. All the muscles of extensors are originating from lateral epicondyle. It means from here the muscles will start and they go like this. They go backside like this. Clear? So what I'm telling you is that this part is the medial epicondyle, and this part is the lateral epicondyle. So medial epicondyle is called as common flexor origin. Sir, why are you telling this? देवेश मिश्रा, what I was telling you is that ये होता है medial epicondyle और ये है lateral epicondyle. So anterior forearm में जितने भी muscles है ये सारे flexors है, flexion के लिए use हो जाएंगे, ठीक है? तो ये सारे flexors जो है they start from medial epicondyle, यहाँ से शुरू होता है. So इसलिए इसको common flexor origin बोलते हैं. Opposite to that इसको common extensor origin बोलते हैं क्योंकि all the extensor muscles they start here and go back. Clear now? Right. Because whenever I'm drawing all these muscles, I won't tell you what is the origin because you know the origin now. Common flexor origin. Fine. All of you now pay attention. Don't write anything. All of you pay attention here. There is a muscle, flexor muscle. It should start from medial epicondyle. So it will start from medial epicondyle here. Look here. And this muscle goes all the way and inserts to the radius. And it is inserting to the radius. Now, few important things I want from you is that origin, medial epicondyle. Where is it inserting? This muscle is inserting onto the anterior side because I'm discussing anterior muscles. Anteriorly, where it is inserting onto the radius side. So, can I call it as anterolateral aspect of radius? अब ये lateral कहाँ से आ गया? What is this lateral? Simple thing. This is the medial border. This is the lateral border. So muscle is attaching to the lateral side. So anterolateral aspect of radius. Okay. Now, this muscle, whenever I'm contracting this muscle is useful for this motion here. What is this motion here? What is this motion called as? This is called as pronation. This is called as pronation muscle. Okay. This is called as pronation muscle. If you exactly look at this muscle, guys, this muscle looks like a small tree. This muscle looks like a small tree. Okay. A small tree is attached like this. That is why it is called pronator teres. It is called as pronator teres. That is why it is called pronator teres. So the first superficial muscle here is pronator teres. Clear, everyone? Yes. Now look at the next muscle. As we are discussing the diagrams, they become few. Don't worry about that. I don't want to draw the same picture again and again. All of you know we have got carpal bones 1, 2, 3, 4, 5, 6, 7, 8. Right? We have also got phalanges 1, 2, 3, 4, and 5. Clear? So this is your radius bone, this is your ulnar bone. So this will be your 1, 2, 3, 4, and 5 phalanges. Sir, where are the digits? I did not draw the digits here. Okay. So what are these 8? These 8 are carpal bones. And what are these 5? These 5 are called as metacarpals. MC stands for metacarpals. Where are the phalanges? I did not draw. Right. All of you should concentrate here. Come on. All of you should concentrate here. Sure, Devesh Mishra, I'll tell you in Hindi also. Look here. The second muscle, from where should it start? Again, medial epicondyle. It started from medial epicondyle. Now look here, don't comment. This muscle is going towards the radial side. This muscle is going towards the radial side, coming down like this, coming down, coming down, coming down, and it is attaching to the second metacarpal. Okay. First important point. Origin of this muscle, medial epicondyle. Where is this muscle inserting? It is inserting to the second metacarpal. Okay. What is the name of this muscle? Look here. This is which muscle? Flexor or extensor muscle? Flexor muscle. So flexor. It is going towards which bones? It is going down towards the carpal bones. Carpi. Carpal bones on which side? Radial side or ulnar side? Tell me, guys. For example, if I'm dividing this carpal bones like this will be the radial side of the carpal bones. This is the ulnar side of the carpal bones. Now this muscle is going towards the radial side of the carpal bones. So flexi carpi radialis. Flexi carpi radialis. So the second muscle after pronator teres, flexi carpi radialis. Flexi carpi radialis. Look at the third muscle now. All of you look at the third muscle. After discussing these muscles, I'll give you a break, guys. One, two, three, four, five, six, seven, 8. Okay. Now, what is the next muscle, sir? The next muscle, from where does it start? Again, it will start from the medial epicondyle. Thank you, Walid Islam. Thank you so much. So it starts from the medial epicondyle. Now, where is this muscle going? Sir, this muscle is going in the center. It is not going towards the radial side, nor it is not going towards the ulnar side. Okay. Right. So guys, this is a very important class. I want all of you to share this link to your friends, because forearm muscles get the maximum number of MCQs and the most difficult part, I guess. So this muscle has got a very long tendon, and this tendon branches and it attaches to the carpal bones like this. Okay, it attaches to the carpal bones. Now look here very, very carefully. Origin of this muscle, medial epicondyle. Where it is inserting? It is inserting to palmar aponeurosis. Palmar aponeurosis. A palmar aponeurosis, sir, what is this again? Simple thing, guys. Tendon has come like this. It divided into many branches. All the branches together, they attach to a sheath. That is called palmar aponeurosis. Look here. It is coming like this all the way. It is dividing into many branches. It is attached to a sheath here. This is called palmar aponeurosis. Okay? Look here. Sir, what is the name of this tendon? Where is it is attached? It is attached to the palm region. So the name of the muscle is palmaris. It has got very long tendon. So longus, palmaris longus. Very good, Dr. Benedict. It's not important. Very good. Thank you, Hillary. Thank you so much. Even I have a lot of friends from Kenya. So it is palmaris longus. Palmaris longus. Now look here, guys. You are teaching me muscles, but you are not telling me any clinical point. See guys, there is one very important clinical point. There is a long tendon here, right? This muscle is absent in 10% of the individuals. I don't know if it is there for me or not, but it's absent in 10% of the individuals. So it is not that important muscle. So that is the reason why what doctors have done is that it has got very long tendon. So why don't we use this tendon for tendon grafting surgeries? Yeah. So you use this for tendon grafting surgeries. Tendon grafting surgeries. Anfal Kavi, thank you so much, Anfal. Thank you so much. Excellent, guys. You guys are really excellent. Thank you so much. Tendon grafting surgery. What is a tendon we use? We use palmaris longus. I have told you this point when I was discussing the lower limb itself, if you remember. Right? AB Khan, excellent. AB Khan, thank you so much. Right. All of you are clear so far? We have discussed three muscles. Now we are about to finish the forearm. Now don't worry, don't be shocked. Look here now. All of you, now look here. Before you comment, by the time you comment, I'll keep on drawing this very fastly. Right. Clear now. Look, we are set now. So in the carpal bones, guys, this is the radial side, this is the ulnar side. So from the radial side, if I count down the carpal bones, look here. She likes to play. She likes to play. P stands for pisiform. And after that, try to catch her. Head stands for hamate. It means in the edge here, this is pisiform, this is hamate. So if I want to write here, this will be pisiform and this will be hamate. Very clear, right? So what are you trying to teach us? What am I trying to teach you is that there is a muscle, the fourth muscle, it also starts from medial epicondyle because it is a common flexor origin, and this muscle now it is moving towards which side? Ulnar side, not radial side. It is moving towards ulnar side, and this muscle has got a tendon. Look here very carefully. All of you look here very carefully. There is a ligament, guys. There is a ligament that is attached from the pisiform bone to the hamate bone. Can you look at this ligament? Let me dark it up. There is a ligament that is attached from pisiform bone to hamate bone. So this ligament is called as pisohamate ligament. Pisohamate ligament. Pisohamate ligament. There is another ligament that is attached from hamate bone to the metacarpal bone. Hamate to metacarpal. So this is called as carpo metacarpal ligament. Carpo metacarpal. It is attaching from carpal to metacarpal. Right. So this muscle comes down all the way. Its tendon inserts to pisiform bone. It is inserting to pisohamate ligament. It is inserting to hamate bone. It is inserting to carpometacarpal ligament. And finally, it is inserting to the fifth metacarpal. Okay. What is the name of this? The name of this is, it is a flexor muscle. So flexor, it is going towards the carpal bones, carpi, but carpal bones on the ulnar side, ulnaris. Flexor, carpi, ulnaris. Origin, you know, coming to insertion, it is attached to pisiform bone, pisohamate ligament. Okay. Next, hamate bone. Next, carpometacarpal ligament. Very, very simple. Right? So we shall write it down now. Fourth and fifth important muscle. Now what is this fourth? Flexor carpi ulnaris. Right? Flexor carpi ulnaris. And the last muscle, guys, last muscle, I'm telling you, this is a very important muscle. Out of all, this muscle is very, very, very important. Look here. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5. Okay. So all of you know here we have got digits, or you also called as phalanges. Okay. So what I'm going to do is that let me make a copy of this picture. Let me put it down. Right. Cool. Look here now. All of you should pay attention now. All of you should pay attention. I told you in the starting that there is a triangular process here. This triangular process is called as coronoid process. What is this? This is called as coronoid process. I told you in the starting. Okay. And now I'm telling you one more important thing. One more important thing, that there is also a line on the radius bone. On the see, this is radius, this is ulna. On the radius bone, there is an oblique line here. So I call it as oblique line of radius. Oblique line of radius. Oblique line of radius. Okay. Now look here. There is a ligament that is attached from coronoid process till the oblique line of radius. So this ligament is in the form of an arch. So I call it as arcuate ligament or arcuate ligament. Arcuate ligament. It is called arcuate ligament. Let's start. Origin of this muscle. Same again, medial epicondyle. Not only medial epicondyle, it also originates from the coronoid process. It also originates from the arcuate process, arcuate ligament. It also originates from the oblique line of radius. So this muscle comes down all the way like this. It comes down all the way like this. Okay. And this muscle has got very long tendons. Very, very long tendons. And look, where are these tendons getting attached? These tendons here, they come and attach to this. So if I'm putting it like this is called distal phalanx, this is called middle phalanx, this is called proximal phalanx. So all these tendons are coming and attaching to the middle phalanx, attaching to the middle phalanx. Here I have middle phalanx, here I have middle phalanx, here I have middle phalanx, here I have middle phalanx. But for the thumb finger, I don't have middle phalanx, I have only distal phalanx, I have only proximal phalanx. So that is the reason why these muscle tendons are attached to 1, 2, 3, 4. So 4 of these middle phalanx. So that is the reason why it has got only 4 tendons. Okay. Now this muscle is called as a flexor muscle, right? And this muscle is attaching to digits. It is attaching to digits. So digitorum. And it has got tendons very long. So longus. Wrong. This is not the muscle. We are discussing this muscle in which group? Superficial or deep? Superficial. So superficialis. Flexor digitorum superficialis. Okay. So the name of this muscle is flexor digitorum superficialis. Flexor digitorum superficialis. So when I tell the name of this muscle is flexor digitorum superficialis, the opposite of superficialis will be deep. So in the deep muscles, one muscle we should discuss, flexor digitorum profundus. Profundus means deep. All of you. Let me wait for 1 second and ask all of you, are you understanding it? Yes, it has got 4 tendons. It has got 4 tendons over here. Are you all understanding it, guys? Sanyasi Pandey, thank you so much, guys. You are waiting, literally you are waiting for all my explanations and all. Very good, guys. So guys, flexor digitorum profundus. And what did I tell you, guys? I told you that flexor digitorum superficialis will attach to middle phalanx. So we have got only 4 middle phalanx, so 4 tendons. But flexor digitorum profundus will attach to distal phalanx. Distal phalanx. When I tell distal phalanx, what is a distal phalanx? See, this is a distal phalanx. This is a distal phalanx, right? This is a distal phalanx, this is a distal phalanx, this is a distal, and this is a distal. So how many distal phalanxes I have? 5. So profundus also has got 5 tendons. So it has got 5 tendons. Whereas superficialis has got only 4 tendons. It has got only 4 tendons. If you remember these things, guys, if you remember these things, it would be done. And what are the second and third muscle? Second and third muscle is very simple, guys. Very simple. There is one muscle which is in the form of a square shape. I call it as a quadratus muscle, right? Pronator quadratus. Okay. In the same way, there is another muscle. Look here, all of you. There is another muscle which flexor origin, right? Flexor origin. So flexor, and this muscle goes all the way and attaches to your thumb finger, to your thumb. You know, what do you call thumb in the Latin? Pollicis. What do you call the great toe in the leg? Pollicis. This is called pollicis. So this muscle comes like this all the way, and from here this muscle gives a very long tendon which attaches to the thumb, right? So it is a flexor muscle, so I call it as flexor. It is attaching to the thumb finger, so I call it as pollicis. It has got a long tendon, longus. Flexor pollicis longus. Flexor pollicis longus. We are done with all the flexors. Did you understand? I'll tell you nerve supply, but before that we are done with all the flexors. Did you understand all the flexors clearly without any doubt, guys? Yes or no? Right? You understood it, right? You understood it. You understood. I know you guys are perfect. You will definitely understand. Excellent. Thank you. Thank you. Thank you. Sir, nerve supply bhi bol do na. Sir, nerve supply. What is the nerve supply? You know, all the muscles of anterior compartment. Now, posterior compartment, don't ask me nerve supply. When I discuss posterior compartment, you should not ask me nerve supply, because I told you posterior compartment nerve supply is radial now. Radial now. Okay. So, Robert Medina, yes. Simple thing, Robert. Pronator teres is located here. It is responsible for pronation. Flexor carpi radialis. Flexor point is this one, right? This muscle goes cross like this towards the radial bone. This is the radial, this is ulnar bone. Let me show it to you like this, right? This is the radial, this is the ulnar. Now this muscle goes all the way like this towards the radius bone, and it is attached to the radius, right? So this is called flexor carpi radialis. Same way, from the flexor origin, muscle is going towards the ulnar side, crossing the carpal bones. So flexor carpi ulnaris. Okay. Next, muscle from the flexor side going all the way like this, giving long tendons in the palmar region. So palmaris longus. Okay. Palmaris longus. Another muscle going all the way like this, attaching to your thumb. It is a flexor muscle. So flexor attaching to the thumb. So pollicis. It has got a long tendon. So longus. Flexor pollicis longus. Origin and insertion VK, I have already explained to you clearly about the origins and insertions. So I want you to go back in the live, after the live is completed. I want you to go back and look at these origins and insertions. Okay. Right. So what is the nerve supply? What is the nerve supply is all the nerve, all the muscles of the anterior compartment are supplied by median nerve. All of them are supplied by median nerve, except, look here now. I'll give you an open statement that all flexors of forearm are supplied by median nerve except 1.5 muscle. 1.5 muscle. What is that one muscle? What is that half muscle? One muscle is flexor carpi ulnaris, right? Don't confuse again. This is your flexor carpi ulnaris. Ulnaris, ulnar nerve, right? This is supplied by ulnar nerve. And what is that half muscle? Look here very carefully, very carefully. This is your flexor digitorum superficialis. If I divide this flexor digitorum superficialis into two parts, for example, like this, look here, I'm dividing this flexor digitorum superficialis into two parts. Okay, which is on the ulnar side is called as the medial part, which is on the radial side is called as the radial part. Medial side is called medial part, radial side is called radial part. So this medial side muscle, whatever is there, that is supplied by medial nerve. The radial side muscle, whatever is there, as usually that will be supplied by median nerve. Clear, all of you? So what is that? What is that half muscle? That half muscle is median half of flexor digitorum superficialis is supplied by ulnar nerve. Other than this, the remaining all muscles are supplied by median nerve. All of them are supplied by median nerve. Is everyone clear? Medico, empathic medico, you have got 25 days remaining. Don't worry. I have already recorded lower limb. You can watch lower limb, and today will be the complete discussion of the upper limb. So even you can watch the upper limb. So within, I think, 4 or 5 days you can complete it. Remaining days you can revise it. Okay, don't worry about that. Now I want to close this session, not session. I just want to give you a break by telling one last clinical point. One last clinical point. Okay, one last clinical point. Look here now. All of you look here. Look here. Let us say that let me draw this. Right, guys. So this is the hand. Right, guys. So this is the hand region. Yes, VK. I'll go even through the palpation of the muscles also. Don't worry. So this is the hand region, guys. Now in this hand region, starting I told you one muscle. You remember? Yeah. So there is a muscle. There is a muscle that comes all the way down like this. Yeah. This muscle has got very long tendons. This muscle is coming into the palm, dividing into very long tendons. Can anyone name what is that muscle? Excellent, Dr. Benedict. Palmar is longest. Excellent and excellent. Palmar is longest, right? So this muscle comes like this and it ends up like this, ends up here. Very good, all of you, very good. I'm really happy that you understood all my classes, guys. I'm really happy. Now this muscle has got tendons, right? So let me little bit compress this picture. Now these tendons, they go like this all the way into each finger. These tendons are going into each finger like this. Okay, all of you look. Now tendon has to be covered by something because you need to protect the tendon. So tendon is covered by a sheath. This is called as synovial sheath. Tendon is covered by a sheath called as synovial sheath like this. The entire tendon is covered by a sheath and this sheath is called as synovial sheath. This is called as synovial sheath. Okay, between the sheath, Between the two synovial sheaths, now here comes the interesting part. Between the sheath, I have got a tissue like this. Between the sheath, I have got a tissue in this way. Now this tissue is called as palmar aponeurosis. What is this tissue called? This is called as palmar aponeurosis. This is called as palmar aponeurosis. And what is the name of this muscle? Palmaris longus. Palmaris longus. Now, sir, what are you trying to tell me? What am I trying to tell you is that if this is my hand, this will be my lateral side and this will be my medial side. Okay, this will be my lateral side and this will be my medial side. All of you look here. On the medial side, whatever palmar aponeurosis I have, if that palmar aponeurosis gets stiff, what I'm trying to tell you is that on the medial side, whatever palmar aponeurosis is there here on the medial side, if that palmar aponeurosis becomes so stiff, right? So exactly I'm talking about this part of the palmar aponeurosis. If this part of the palmar aponeurosis, see this part of the palmar aponeurosis, it becomes stiff. Okay? What will happen? Not abscess, right? Not abscess. If it becomes stiff, then what will happen is that this part will contract like this. When this part will contract like this, you will see in the palm of a patient this kind of appearance. You would see in a patient this kind of appearance. You see this very clearly. You see how the contraction has happened because of the fibrous tissue, and which side? On the medial side. On the medial side. And this condition is called as Dupuytren's contracture. What is this called? Dupuytren's. Excellent cyanide. Very good. Excellent, Dr. Munia. Perfect. Excellent, Dr. Munia. Your answer is also right. Osama Sheikh. Excellent. Dupuytren's contracture. So, all of you know what is Dupuytren's contracture. Now, you will get 1 mark if you see this picture in the exam. You will get 2 marks if they ask you what is Dupuytren's contraction. Dupuytren's contraction is nothing but on the medial side of palmar aponeurosis, if there is contraction, if the tissue is brought together, right? Because of that, there is a constriction or there is a contraction of all the tissue here. There is a retraction of all the tissue. That would lead to Dupuytren's contraction. All of you clear? Sir, how can I treat this? Now, how can you treat this is you need to do a surgery. That is called as surgical fasciectomy. You need to cut that fascia there so that the fingers will go back like this, right? They will relax like this. So this is called as surgical fasciectomy. Yes, Dr. Bendig, yes, the surgery. Excellent, Dr. Bendig. VK, Roger that. Yeah. Excellent, VK. Right? Before I give break, one small point, guys. One small point. Dr. Roy is telling release operation. Yes, you have to release the tendons here. Small point is that I told you that this is medial epicondyle, right? I also told you that this is lateral epicondyle. Medial and lateral epicondyle. All of you look now. All of you look. For example, let us say this is my, let us say I'm playing cricket. Okay. Or not cricket. This is the golf. Okay. This is the golf bat. Now what I'm doing is, if I wanted to come, look here. Now I have an aim. Now I'm beating the ball, right? Now if I wanted to beat the ball, what will I do? I will completely pull my hand back. When I'm pulling my hand back, where is the excess amount of pressure impended? It is impended on the medial epicondyle. But lateral epicondyle is constricted here, right? Near the lateral epicondyle, there is relaxation, there is constriction. But near the medial epicondyle, there is a lot of tension, isn't it? So when I'm moving it backward like this, there is a lot of tension that is impended here. And suddenly I beat. So every time when I'm moving like this, a lot of tension that is impended here, that would lead to inflammation of my medial epicondyle. So inflammation of my medial epicondyle is called as medial epicondylitis. I'm having this medial epicondylitis while I'm playing golf. So this type of elbow disorder is called as golf's elbow. Golf's epicondylitis or golfer's elbow. Okay, in the same way, when I'm playing tennis, now how do I play? I don't play tennis like this, right? So what will I do? I will stretch my hand out and then I'll forcefully beat at the cock. So when I'm completely making a slash on the cock, what is happening? I'm extending my forearm. When I'm extending my forearm, common extensor point is lateral epicondyle. So this lateral epicondyle is under high tension. So there can be inflammation of this lateral epicondyle. So it is called as lateral epicondylitis or tennis elbow. It is also called as tennis elbow. Right? Tennis elbow. Excellent, Dr. Munia. Very good. Very good. Very good. So let us, all of you understood, guys. Now, next I'll be teaching you. Next, you know what I'll be teaching you? Next, I will be teaching you regarding the extensor muscles. Now, before I go and teach regarding the extensor muscles, I'm not going to draw because all the basics we have discussed here. Now, regarding the extensor region, I'm going to directly tell you the muscles and you will understand it. Okay. So, did you all understand all the flexor muscles, the superficial, the deep, the origins and insertions, as well as the clinical points? Did you all understand, guys? Yes, Sanyasi. So let us let us VK, I want you to be in the session because you can watch the recorded video later on. But if you have any questions while teaching the later part, so it would be easy though, because I would answer directly. I'm answering everyone's question here. Okay. Okay, VK. So let us take a break for 6 to 7 minutes and then let's just come back. Okay. Hello, hello, hello. Start with saying. All is well. Cyanide, hi, hello, Osama. Welcome back, guys. Welcome back, all of you. Right. So, guys, let us start now. Let us start. We have a lot of things to discuss. Let us finish it. Fatafat. Hello, Dr. Benedict. Hello. Welcome back. Thank you. Thank you. Hello, hello, hello. Yes, yes. Let's start. So, guys, we have discussed. I hope my voice is audible and whatever I'm writing down. I mean, I haven't written down anything, but whatever I'll write down. So, yeah, I think everything is clear for you, right? So, whatever these things, you can see whatever I'm writing here, right? Fine. All perfect. Thank you. So, there is a green signal. Let's start now. We have discussed. Sorry, we have discussed. Sohail Khan. Thank you so much. Thank you so much. Not yet. Right. So we have discussed that there are flexors, there are extensors, isn't it? We are done with the discussion of flexors. Now, when I discuss about the extensors, remember one thing: all the extensors in the posterior compartment are supplied by radial now. Now, what and all of them, they start from the lateral epicondyle, isn't it? They start from the lateral epicondyle. So, can I tell that the common extensor origin is lateral epicondyle? Yeah, I will write it down here that the common extensor origin. The common extensor origin is lateral epicondyle. Common extensor origin is always your lateral epicondyle. Now, what are the muscles? Now, point number one. What is the first muscle? Okay, look here. Origins and insertions are not that important because by now you might know what are the origins and insertions. So, look here. This is called as a brachium. This is called as the radial side. This is called as the ulnar side. So from the brachium to the radial side, this big chunk of muscle, right now when I'm catching it, you can look at this big chunk of muscle here. This muscle from the brachium to the radius, brachioradialis. So the first muscle here is brachio. You know, most importantly, what they'll ask you here, guys, not origins and insertions. Most importantly, they'll ask you nerve injuries. I will give a complete description of nerve injuries very shortly, right? All your MCQs will be covered. Clear? So just trust me. Second important thing. Look here. From the extensor point is lateral epicondyle. From the extensor point, there is a muscle which goes all the way like this, right? So look here, extensor point, this muscle is going all the way like this. It is going along the radius bone, crossing the carpals on the radial side, right? So if I divide it, this is the medial side carpals, this is the radial side carpals. So it is going all the way like this, crossing the carpal bones on the radial side, and this muscle has got a very long tendon. So this is an extensor muscle. So extensor, it is going all the way towards the carpal sides, carpal bones, carpi on the radial side. Radialis, and it has got a long tendon, longus. Extensor carpi radialis longus. So whenever there is longus, there will be brevis. So extensor carpi radialis brevis. Brevis means small tendon. There is a long tendon, there is a small tendon. Fourth important muscle. From the extensor point, this muscle comes all the way like this, and this muscle is attached to your digits. So from here it comes like this all the way, and it divides into tendons, and these tendons, they get attached to the digits. So extensor digitorum. Okay. Extensor digitorum. Very good, Osama Sheikh. Brevis means small. Yes. Fifth muscle. This is called what? Holic. Not holics. What is this called? Pollex. This is called pollex. The toe one is called holics, right? This is called pollex. And what do you call the little finger in Latin, guys? Anyone? Can anyone answer me? What do you call this little finger in Latin? Yeah? The small finger in Latin, you call it as, yes, you call it as, very good, Osama. Excellent. You call it as digiti minimi. You call it as what? You call it as digiti minimi. Excellent. Excellent. Digiti minimi. So look here. From the extensor point, there is a muscle. Extensor point means lateral epicondyle. From the extensor point, there is a muscle that comes all the way like this, and it is attached to your little finger. You call it as extensor digiti minimi, right? This is called as extensor digiti minimi. Extensor digiti minimi. Next muscle. From the extensor point, it comes all the way like this. It is coming towards the ulnar bone. Ulnar bone. It is crossing the carpal. It is crossing the carpals also on the ulnar side, and it is attached here. Extensor point. It is taking a turn towards the ulnar bone, crossing the carpal bones on the ulnar side, and it is coming up. This is called as extensor. Crossing the carpal bones. Carpal bones on which side? Ulnar side. Carpi ulnaris. Extensor carpi ulnaris. And the last muscle is anconeus. You know, anconeus is also called as a screwing muscle. It is responsible for screwing motion. If I wanted to remove a screw, if I wanted to fix a screw, this type of motion is done by anconeus. So anconeus is also called as a screwing muscle. Very, very, very important. This is asked as an MCQ. Okay, this is asked as an MCQ. So all of them are supplied, obviously, no doubt, all of them are supplied by radial now. Muscles of hand are very, very easy, guys. You need not to remember anything in muscles of hand, I'm telling you. Just remember 1, 2, 3, 4, 5, 6 or 1, 2, 3, 4, 5. So these numbers are enough for discussing the muscles of hand. I'll tell you how. But before that, I just want a clarification. I have discussed all the muscles of anterior, posterior compartment. We are done with the forearm. We are done with the actions. We are done with the, the origins. We are done with the insertions. Now, tell me, is it easy for you? Is it easy understanding the forearm, guys? Very good, very good, very good. Thank you. Thank you so much for understanding, guys. Thank you so much. So, study vlogs, love from Swat, Pakistan. Pre-med students, excellent, guys. Learn everything with the concept so that it would be useful for you in the further life. Okay, don't mug it up. Excellent, guys. So let us continue, guys. Now let us continue. Now, from now onwards, yes, VK. From now onwards, whatever I'm teaching you, definitely, I can guarantee right now itself, definitely you will get at least 2 or 3 questions, not 1, 2 or 3 questions, definitely you'll get it. Okay, I want all of you to pay an attention. What are the things I'm teaching here? Look here. This is the humerus. Okay, let me also put another humerus. Let me also put another humerus like this. Okay, now all of you know that this is the medial epicondyle, this is the lateral epicondyle. Here also medial epicondyle, lateral epicondyle. This is also medial epicondyle, lateral epicondyle. I will start discussing muscles of hand. I have not yet discussed, but look here. Now there is a nerve, all of you, there is a nerve that comes all the way like this, and it just passes behind the medial epicondyle. So there is a nerve that comes all the way like this. It comes all the way like this, and this nerve is passing behind the medial epicondyle like this. You see, it is passing behind the medial epicondyle like this. Now this nerve, Roy, it is not radial. You are the one who answered me correctly previously. This nerve is called as your ulnar nerve. Ulnar nerve, from where does it pass? Behind medial epicondyle. So this is the question which is asked. Okay, this is the question which is asked. Second question what is asked is that, for example, I told you compare medial epicondyle with lateral epicondyle. The medial epicondyle, right? The medial epicondyle is much more prominent than the lateral epicondyle. So medial epicondyle has a higher chances of fracture. For example, if I'm falling on an outstretched hand, right? My ventral side, my anterior side is the one which is getting contact with the floor. So what will happen is that my medial epicondyle will fracture. So whenever there is fracture of medial epicondyle, which nerve will be damaged? Ulnar nerve. Which nerve will be damaged? Ulnar nerve. Now look here. Yes. Very good. Look here now. All of you tell me which nerve is damaged in this X-ray. Cyanide, perfect cyanide. I'll tell you about claw hand, but you're right. Which nerve is damaged here? What fracture can you see here? Excellent cyanide, excellent. So this, you see this part here, this is a fracture of medial epicondyle, isn't it? This is a fracture of medial epicondyle. So excellent, guys. Now let us switch on to the next one. What is the next one? Look here. Excellent, all of you. Just pay attention now. Roy is telling evolution fracture. Avulsion fracture of medial epicondyle. Excellent, Roy. Yes, this is called avulsion fracture. Okay. Now look here. This is the humerus bone, right? Now in this humerus bone, this is called as a shaft of the humerus. Now exactly on the shaft of the humerus, let me put up this thing. Exactly, this is the shaft of the humerus. Now there is a nerve that is coming and it is making a turn like this. It is making a turn like this, right? And this nerve is passing through a groove called as a radial groove. So it is making a turn. So if I get any kind of fracture in the shaft, then which nerve will be damaged? The radial nerve. So what I'm trying to tell you is that there is a nerve which comes like this. It takes a turn around the shaft of the humerus. Okay. So if this nerve is damaged, then excellent. All of you med student, miracles world, perfect, guys. So radial nerve will be damaged in case of mid shaft fracture of humerus. Mid shaft fracture of humerus. Next important thing is that, look here again. These two are called as condyles. Medial epicondyle, lateral epicondyle. And the space above the condyle, you call it as supracondyle. What is this region called? Supracondylar region. So there is a nerve that comes like this, passes above the supracondylar region. So this nerve is called as your median nerve. Ayman Kazi, perfect. This is supracondylar region. You are right, Ayman. Median nerve. So if I tell you that supracondylar fractures of humerus will lead to which nerve palsy? Median nerve palsy. Supracondylar fracture of humerus. Clear so far? This is the first basic thing you need to know. How ulnar nerve fracture will happen, how radial nerve fracture will happen, how median nerve fracture will happen. What will happen because of these nerve injuries, I'll tell you later on. Now, all of you, it is a small test for you. Now, you will tell me which nerve fracture will happen, might have happened to this patient. Which nerve fracture might have happened to this patient? Cyanide is killing with answers, cyanide is killing with cyanide answers. Excellent. What kind of fracture is this? What kind of fracture is this? Exactly, this is called as a mid-shaft fracture. Now, in the mid-shaft fracture, I will have radial nerve injury. Very simple. This is what they ask you. This is what I mean by clinical questions. In the next exam, they are going to ask you clinical questions. Now, don't think clinical in the sense it might be so difficult. No, this is how they ask you. Another question. Another question for you. Now, yes. Who will answer me this? What kind of nerve injury will happen in this patient? Osama Sheikh, perfect. Osama, very good, guys. Sanyasi Pandit loves abbreviations. I think he only answers radial nerve as R, ulnar nerve as U. Anyways, you are right. Dr. Bend, excellent, guys. This is a supracondylar fracture. What kind of fracture is this? Supra, above the condyle, right? So here, which nerve will be damaged? Again, your median nerve. Your median nerve will be damaged. Okay, right. Before I move on to the next one last question again. One last question. Now let us see who will answer this. Okay. So which nerve will be damaged in this patient with such X-ray? Which nerve can be damaged? Thank you, Sanyasi. You have updated from R to RAD. Radial nerve. Ayman Qazi, perfect. Munia, Dr. Munia, perfect. Nandini Shiva, excellent, excellent. Roy, you're already excellent. So this is a mid-shaft fracture. Where do you see this in case of, I mean, in this fracture, what do you see? You see the radial nerve injury, right? You see the radial nerve injury, right? Now, before I discuss further about these nerve injuries, first let me finish up the muscles of hand. Again, the muscles of hand, again the same thing. I will write down a box. Okay, I'll write down a box, but all of you look here. Now let me put up this space over here so that I should write the muscles of hand. Let us discuss. Now, all of you guys, whenever I'm showing it like this, look here, you can see a elevation here. You can see an elevation. You can see another elevation here. But this elevation is on the top. This elevation is little bit bottom, right? All of you, this elevation is on the top. This elevation is on the bottom. So these group of muscles are called thenar. So whatever below the thenar is called hypothenar. So this is thenar and this is called hypothenar, right? This big chunk of muscles are called thenar muscles. These are called hypothenar muscles. Now look here. Thenar and we have got hypothenar. Now look here. All of you look here. Now this is my thumb finger. This is my thumb finger. What I am doing with my thumb finger? I am extending it or am I flexing it? I am flexing my thumb finger. So what is this muscle name? Flexor. Flexing of what? Pollex. This is called pollex. Flexor pollicis. And this muscle is short. This muscle is short. It is present within the thenar group. So brevis. Flexor pollicis brevis. Clear? Second important thing. Next, look here. All of you look here. What I'm doing is, okay, let me put it up like this. This is the lateral side, right? This is the medial side. I am laterally moving my thumb finger. So when I'm laterally moving my thumb finger, lateral side movement is called abduction or adduction. Lateral side movement is called as abduction. So the name of this muscle is abductor. Again the same thing. It is of the pollex. Pollicis brevis. Pollicis brevis. Third important thing is that this is my thumb finger. What I'm doing is I'm counting my fingers. When I'm counting my fingers, what am I doing? I am going opposite of each finger. I am going opposite of little finger, opposite of this finger, opposite of the middle finger, opposite of the index finger. So this muscle is called as opponens. What is this muscle called? Opponents. Again, don't forget to mention opponents of what? Opponents of your thumb, pollex. So opponents, pollicis. Opponents, pollicis. Okay, right. Now just compare this with the hypothenar. But before that, one last muscle. I told you if the finger is moving like this away, this is called as abductor. But if the finger is moving towards my body, this is called adductor. Look here now. I'm closing my thumb. I am completely closing my thumb, or I'm completely resting my thumb on the remaining fingers like this. You see, towards my body. So this is called adduction. Adductor pollicis. Adductor pollicis. Very good. Let us compare thenar with the hypothenar. First important thing. Look in the hypothenar. All of you concentrate in the hypothenar part. Hypothenar is this one, right? This is attached to the little finger. Little finger is called digiti minimi. So I'm flexing the digiti minimi. I'm flexing the digiti minimi. So can I call it as flexor digiti minimi? Flexor digiti minimi. Second important thing. What I'm doing is, look here. What I'm doing this, what is this action? Now you will tell me what is this action called? I'm moving my little finger away from my body. Moving my little finger away from my body. So this is called abduction or adduction. Look here. I'm moving it away. I'm moving it away. Again, I'm bringing it back, but I'm moving it away. I'm moving it away. Excellent. Excellent. So this is called abductor. Abductor of what? The little finger, digiti minimi. Digiti minimi. Third important thing. Not only the thumb, even I can take this finger and touch the thumb. Look here. You see? Even I'm bringing my digiti minimi. And touching to my thumb. It means this is called as opposition function, right? So opponents digiti minimi. Opponents digiti minimi. So did you all understand? And finally, the last muscle in the palmar region, which is located in the hypothenar group, that is called palmaris brevis. Obviously, when I told palmaris longus, there will be palmaris brevis, right? Palmaris longus is coming all the way like this. I told you also, what is that? Dupuytren's contracture. So here it is palmaris brevis. So these are all the thenar and the hypothenar group of muscles. So now you understood what are the names of these muscles. You understood what are the functions of these muscles. I mean the actions. You should understand what is the nerve supply. I'll tell you later on. Right. So within the hand, I have got thenar muscles. I have got hypothenar muscles. Hypothenar muscles. Now look here. I have got 3 more groups of muscles. Thank you, VK. Thank you so much for your comment. Thank you so much. Right. I have got remaining 3 groups of muscles. What are they? Now, look here, all of you. Look here. There are muscles that are located in between my fingers. So here I'll have 1. Here I'll have 2. Here I'll have 3. Here I'll have 4. How many? 1, 2, 3, 4. So these 4 muscles, they are like worms, right? I hope all of you know what is a worm. So they are like worm like this. You know, they are like worms, right? I hope all of you know what is Ascaris lumbricoid. Ascaris lumbricoid is a worm, isn't it? So these muscles, they look like Ascaris lumbricoids. That is why they call it as lumbrical muscles. Lumbrical muscles, or you can also spell it as lumbricals. Why it is called lumbricals? Because they look like Ascaris lumbricoids, worm-like muscles. So they are called as lumbricals. Right. Next, there are 4 muscles that are located on the palmar side here. 1, 2, 3, 4. Even on the back also, 1, 2, 3, 4. And these muscles are located between the bones. Bones are called as ossei. Between the bones, interossei. So some are 4 are located on the palmar side, 4 are located on the dorsal side. So these are called as palmar interossei. Another one called as dorsal interossei. Dorsal interossei. How many lumbricals I have? 4. How many palmar? 4. How many dorsal? 4. All your muscles of hands are finished except the nerve supply, which I'll discuss. All your muscles of hands are finished. Easy peasy. Easy, guys. Before I discuss the functions, easy. Right. Very good. Now, look here. What are the actions of thenar muscles? You already know. What are the actions of hypothenar muscles? You already know. When I tell the action of lumbrical muscles, whenever I tell from today onwards lumbricals, the first thing you should do is put your hands like this. All of you, put your hands like this. When I tell lumbricals, you see an L shape over here, L shape, L for lumbricals, right? L shape. Now, what is the action of lumbrical muscles? What is this joint called as, guys? What is this joint called as? This joint is present between the digits as well as the metacarpals. So this joint is called as metacarpophalangeal joint. Metacarpophalangeal joint. This is called as metacarpophalangeal joint. So now you tell me, when I do like this, am I flexing my metacarpal joint or extending it? Am I flexing it or extending it? Tell me. Am I flexing this or extending it? Very good, cyanide. Very good. What am I doing? I'm flexing my metacarpophalangeal. Now look here. I'm extending my metacarpophalangeal. Now I'm flexing my metacarpophalangeal. So what I'm trying to convey to you is that flexion of metacarpophalangeal joint. HS vlogs. Good evening. Good evening. Very good evening. Flexion of metacarpophalangeal joints. And look here. All these are phalanges. All these are phalanges. Between the phalanges also I have got 2 joints. These are called as interphalangeal joints. Between the phalanges, interphalangeal joints. Now overall look here. What am I doing? Flexion of metacarpophalangeal joints and extension of interphalangeal joints. I'm not flexing them, I'm extending them. Flexion of metacarpophalangeal, extension of interphalangeal joints. Extension of IP joints. IP joints means interphalangeal joints. HS vlogs, thank you so much. Thank you so much. So, you understood what is the function of lumbricals? From today onwards, if anyone asks you what are the function of lumbricals, just show them this. Okay? Just show them this. Now, instead of closing all these fingers, just open all these fingers and show them this. Okay? Flexion of metacarpophalangeal joint, extension of interphalangeal joints. Now, yes, Dr. Bendit, I'll tell you what is claw deformity. I will also tell you what are the tests which we do. Look here now. Palmar interossei. Simple thing. P for pad. P for pad. What is D? D for dab. P for pad and D for dab. Now what is pad? Look here. P stands for palmar interossei, which are located on the palmar side. Adduction. AD stands for adduction. What is adduction? Look here. I am bringing all my fingers towards each other, closing all these fingers, right? So this is called adduction. I am medially closing all these fingers. This is called adduction. When I open all these fingers, this is called abduction. So palmar interossei are responsible for adduction, whereas dorsal interossei are responsible for abduction. Palmar are responsible for adduction. Dorsal are responsible for abduction. So simple terms, opening the fingers, closing the fingers. Okay. In a layman language, opening and closing. Hassani. Hi Hassani. Right. So you understood thenar, hypothenar, lumbricals, palmar interosseous, dorsal interosseous. The last thing we are left is what is the nerve innervation. Now, what is the nerve innervation is that, guys, look here. Very, very simple. All of you look here. There are only two nerves, median nerve and ulnar nerve. Median nerve and ulnar nerve. Look here. The first three here, all these thenar muscles, the first three thenar muscles are supplied by median nerve. Median nerve. Next, coming to lumbricals, I told you how many lumbricals are there? 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, and 4. Clear? 1, 2, 3, and 4. Now, coming to lumbricals, the first lumbrical and the second lumbrical, both of them are also supplied by median nerve. So, how many muscles are supplied by median nerve? We have got 3 in the thenar, 1, 2, 3, and 2 in the lumbrical. 1, 2, 3, 4, 5. So, completely 5 muscles in the hand are supplied by median nerve. Then what about the rest? Remaining all of them are supplied by ulnar nerve. Remaining all of them are supplied by ulnar nerve. Okay? Remaining all of them are supplied by ulnar nerve. So, remaining all by ulnar nerve. Okay? Remaining all are supplied by ulnar nerve. Clear? Now, see guys, how many MCQs you have covered here. I will also make you to do the questions. There are remaining questions left there. Now, you might ask here, sir, why did the God, why did the God completely make the human system in such a way that, why did he leave that last thenar muscle? You told me the first thenar are supplied by median nerve. Why not the fourth one also? He would have supplied, it would be easy for me to learn. But you know, nature doesn't work like that. You know what? Thenar muscles are located here, right? Now all of you pay attention here. From here the ulnar nerve comes, because on the ulnar side ulnar nerve only will come. See, ulnar nerve will come like this. All of you look at my hand. Ulnar nerve will come like this all the way. It come like this all the way. It will enter into the hypothenar. That is why all the hypothenars are supplied by ulnar nerve. It will make a U-turn like this, and it will come and it will end in the thenar muscles. So it is coming all the way and it is ending into the thenar muscles. If I ask you a question, where it is ending exactly? It is ending into this adductor pollicis muscle. Into the adductor pollicis muscle. Okay, here we have got adductor pollicis. This ulnar nerve is coming all the way and it is ending into this adductor pollicis. So most of them, you know what they tell? They tell that ulnar nerve, it will run all the way here and finally it will die in the adductor pollicis. So that is the reason why, if someone asks you what is the graveyard of ulnar nerve, you have to tell the graveyard of ulnar nerve is adductor pollicis. Why? Because ulnar nerve is ending in the adductor pollicis. Clear? So adductor pollicis, one more MCQ you have got here. That is, what is why it is called as a graveyard of ulnar nerve? Why it is called as a graveyard of ulnar nerve? Because it is ending here. Adductor pollicis ending here. So it is called graveyard, because all of us one or the other day, by God's grace, we have to go to the graveyard, right? So we are officially done with all the muscles. We are done with all the muscles of your upper limb. All of them. Are my explanations clear, guys, so far? Because now I'm gonna discuss all the nerve injuries. Are my explanations clear? So far you understood everything without any doubt? Right. All of you look now. All of you look. Yes, Yogesh, this session, the reason why I'm teaching all this so clearly, right, thread by thread, everything is for the first year students mainly, as well as the exam going batch. Okay. So definitely this session is meant only for the first, second years as well as the exam going batch. That is why I'm mixing up the important things at the same time. I'm mixing up the basics as well. Okay. Even you can watch it. Thank you, Osama. Thank you so much. Right. Now let us completely concentrate on nerve injuries. I'm not discussing this in detail. You know why? Because most of these nerve injuries you already know. Let us start with the ulnar nerve. Always remember, always remember that ulnar nerve root value is C81. Sir, should I remember this root value? Yes, because in the exam they will ask you, a patient had got an injury, C81 is cut off, or there is an injury to C81, which nerve will be damaged? Ulnar nerve. Okay, C81 is ulnar nerve. Now, you know what? Ulnar nerve is also called musician's nerve. Musician's nerve, because most of your hand muscles, they are supplied by ulnar nerve. So if I'm moving my hand like this, if I'm able to, play a piano, if I'm able to play a guitar, it is all because of my hand muscles, and this is because the nerve innervation of ulnar nerve, that is why it is called as musician's nerve, because it is responsible for fine movements of my hands, fine movements of my hands. Very, very important point, guys. You would not at all find this information, whatever I'm telling you in anatomy, you will find it in clinical subjects like orthopedics. Okay. I'm putting all of that here itself so that wherever you go regarding the ulnar nerve, this will be the perfect information. Now, what is that? What is that? Is the first important point is that whenever ulnar nerve is damaged, patient will have flexion of these two fingers. This is called as ulnar claw. This is called ulnar claw. Okay. So all of you know what is ulnar claw. So this is your ulnar claw. Right. So I hope it is clear. Ulnar claw. Pope sign, Osama Sheikh. Pope sign is different. Pope sign is different. I'll tell you. This is ulnar claw. Second important thing. Second important thing is that, okay, patient came to me telling that, doctor, I don't know why my fingers are like this. Now you will tell you have got ulnar claw, your ulnar nerve is damaged. Now patient won't believe. You have to show him some proof. What is the proof? I will do few tests. And if you fail in those tests, it means your ulnar nerve is damaged. So can you, doctor, please tell me what are those tests? Those tests are called as BCDE test. What are those tests? BCDE test. What is B stand for? B stands for book test. B stands for book test, or it is also called as formant sign. Book test or formant sign. What is formant sign? For example, look here. You are a doctor. I am a patient. You are giving me this paper to hold it. How will I hold it? Normal patient will hold it like this, right? Normal patient will hold it like this and they will take the paper. But a patient with ulnar claw will hold it in this way. You see, he is flexing the interphalangeal joints. He is flexing the interphalangeal joints. What did I tell you? Normal function of ulnar nerve, extension of interphalangeal joints and flexion of metacarpophalangeal joints, if you remember, right? But right now what is doing? He is doing the opposite thing. He is extending his metacarpophalangeal and flexing his interphalangeal joint. So he will take it like this. So this flexion is called as formant sign. This is called formant sign. Okay. So formant sign is basically done to check which muscle, adductor, pollicis muscle. So if there is adductor pollicis palsy, or let us say The paralysis of this muscle, this will lead to this. So what is the next test? What does the C test stand for? C test stands for card test. C test stands for the card test. Excellent, Roy. Excellent. You're right. Because of unopposed action. Card test. What is this card test? What is this card test is that this card test is basically done to know the function of PAD muscles. What is P? P stands for Palmar interossei. Palmar interossei. So what does Palmar interossei do, guys? Palmar interossei, what does they do? Come on. What does it do? Palmar interossei. Now look, if palmar interossei activated, my fingers come close to each other. Okay. Now, patient will tell doctor, I can close my fingers very nicely. Now, doctor will tell, let us do a test. What doctor will do is that he will put this paper in between his fingers like this. He is putting his paper in between his fingers. Now, he is telling, I will pull the paper with the help of your palmar interossei. Contract your fingers so tightly that this paper should not slip. But you know what will happen? The paper slipped away. Why? Because the patient palmar interossei is not closing the fingers properly. It is weak. Why? Because of ulnar nerve damage. So this is called as card test. What is this called? This is called as card test. All of you can look at a picture here. This test which you can see here, this is called as card test. Right? This is called as card test. Miracles World, Osama Sheikh, yes, it is adduction. Nandini Shiva, yes, it is adduction. Excellent. All of you. Very nice, guys. You understood it. This is called as card test. Okay. Yes. Now you can see this picture. This is called as card test. Fine. Now look at the next one. Fourth important one. Not fourth, the fifth important one. I'm sorry. Fifth important one. You told me B for book test. You told me C for card test. Then what is D? D stands for adductor pollicis longus. Adductor pollicis longus test. Even adductor pollicis longus is supplied by, you know that, the ulnar nerve, right? What is adductor? What is adduction, guys? If I'm closing my thumb towards my body, is this called adduction? If I'm closing my thumb towards my body, this is called adduction, right? Now, what doctor will do is that, he will put a pen here. What will he do? He will put a pen here and he will tell the patient to close it. For example, if your muscle and my muscle is working normally, against the resistance of this pen, I will try to close it. Okay? But this patient, because of this resistance, he will not able to close. He'll tell doctor, it is finding difficult for me to close because my ulnar nerve is damaged. You're getting it? This is called as adductor longus, or simply called as pen test. Pen test. Clear? Pen test. And the final test, guys, A, B, C, D, B, C, D, E. E stands for Igawa's test. Igawa's test. Doctor, you check my palmar interossei, then why don't you check my dorsal interossei? So I will check dorsal interossei by Igawa's test. Dorsal interossei by this Igawa's test. Okay. Look at the picture now. I think I don't have a picture of Igawa's test. Right, I don't have a picture of Igawa's test, but anyways, just remember it, guys. Need not to look at the picture. Dorsal interossei, Igawa's test. We are officially done with the ulnar nerve. Any question right now, if I ask you about ulnar nerve, this information will be enough. Okay, let us do these questions, guys. Look here now. Who will tell me this answer? Which nerve is passing through the medial epicondyle? Tauhidul Tanvir, abduction test, you are right. What you wrote is right. It is abduction test. Yes. Yes, Milan, this will be uploaded, not deleted. Right? Medial epicondyle. Very good, all of you. That will be your ulnar. Very good. Right. Now, who will tell me this? This is a tricky question, guys. This is a tricky question. Which among the following muscles receives dual nerve supply? Dual nerve supply. Dual nerve supply. It means a single muscle receiving two nerve supplies. I have already told you that there is a muscle. The medial half is supplied by ulnar and the remaining half is supplied completely by medial nerve. And what is that? Excellent. Dr. Benedict, excellent, excellent. Roy, excellent. Dr. Nikhat, excellent. So the answer is flexor digitorum superficialis. Flexor digitorum superficialis. Okay. Flexor digitorum superficialis. I told you there is a muscle like this, right? If I divide it, this is supplied by ulnar nerve and this is supplied by median nerve. Okay. All of you tell me, all of the following show ulnar nerve injury except in ulnar nerve injury, what all things will I find? So this question is kept for you guys. This question is kept for you. I want you to answer it. I'm not telling the answer. Look at the question. Look at the question. He's telling here is except. Except what? Excellent. Ikra. Ikra, excellent. Dr. Benedict, excellent. Excellent cyanide. Excellent. The answer would be B. Okay. Because adductor we have already tied, right? A, D, D, I told you. In case of BCDE test, what does D stand for? Adductor pollicis longus test. Right? Fine. So let us continue. We are done almost. We are almost done, guys. We are almost done. So we are done with ulnar nerve. The next nerve we shall be discussing very fastly is the radial nerve. Now there is no need to tell how radial nerve injury will happen. And by the way, ulnar nerve I told you it would be what? Ulnar nerve is C8T1, right? Now radial nerve will be C5T1. Radial nerve will be C5T1. And if radial nerve damage is there, then the patient will have what? This kind of thing. What is this? Wrist drop. Wrist drop for radial nerve. And you know one more thing, that in the Saturday night, what most of them do is that Saturday night the workers, they will put their hand on the chair like this and they'll fall to sleep in this way, right? They are putting their hand on the chair, they're resting like this and they are sleeping in this way. So what will happen is that the radial nerve here gets compressed. This would lead to a condition called Saturday night palsy. What is this? This is called Saturday night palsy. Now you party a lot, you drink a lot and think tomorrow is a Sunday. Sunday is for release of hangover. So what you do is that you rest like this on the chair, you know. This is what you do, right? What we do basically. So median nerve. Saturday honeymoon night, Osama, on honeymoon, we don't rest our hand like this, right? We don't use our hands. We don't rest it on the honeymoon day, okay? Unless and until your partner is bored enough, you don't rest your hand and sleep your own way, okay? Right, so median nerve. Right. So coming to median nerve, Wherever you go, guys, all the muscles of forearm are supplied by median nerve except 1.5 muscle I told you. Even in the arm or hand also, the nerve supply, it is median nerve. Mostly it will be ulnar nerve, but it is median nerve. But guys, all of you tell me, whenever you're doing a lot of work, most pressure or most muscles which are involved here are your forearm muscles, because majority are your forearm muscles, and majority of the forearm muscles are supplied by median nerve. So that is the reason why median nerve is also called as laborer's nerve. Laborer's nerve, or it is also called as your eye of hand. Eye of your hand, because this is the main nerve in the forearm. This is the main nerve of your forearm. If median nerve is not there, if median nerve is damaged, then you can't work anything, guys. It will be very difficult for you to work. Yes. Now look here. If median nerve is damaged, yes, all of you are ready with your answers. That patient will have ape thumb deformity. Ape thumb deformity, right? The ape thumb deformity, the hand will go like this. This is called ape thumb deformity, right? Ape thumb deformity. Or I can also call it as in median nerve, the patient looks like this. He will be pointing his finger. So it is also called as pointing finger syndrome. Not syndrome, symptom. Pointing finger symptom. Okay. And one very important thing. Very important thing. Which nerve is responsible for ulnar claw? Which nerve is responsible for ulnar claw? I told you previously, ulnar nerve. Ulnar nerve is responsible for your ulnar claw. Now, I am telling you one very interesting and shocking point, which might not be shocking for most of you who have good basics. Ulnar claw is also because of median nerve. Remember this thing. These are, guys, these are the Bible points, ulnar claw is not only damage to ulnar nerve, but also damage to median nerve. Damage to median nerve and ulnar nerve together, they will cause your ulnar claw. Remember this thing. Okay? Not simply ulnar nerve. And obviously, if medial nerve gets compressed, there is no fun in telling this. If medial nerve gets compressed, patient will have carpal tunnel syndrome. All of you know. Carpal tunnel syndrome. Carpal tunnel syndrome. Carpal tunnel syndrome, right? So lastly, guys, I'll be closing this by teaching you carpal tunnel. We shall do some MCQs on that. Finish this session, okay? Carpal tunnel syndrome. And by the way, guys, I want to tell you that tomorrow also I have session on anatomy. Tomorrow at the same time at 7 o'clock, I'm going to deliver you the anatomy session. We shall be discussing abdomen. Okay, we shall be discussing the abdomen and the leftover topics of today's class. Okay, and important thing is that on Sunday there is a live interaction. Okay, there is an integrated session. What I will be doing is that along with me there will be another doctor by name Dr. Shubham, who has been teaching you surgery, right? So we both will be sitting side to side, and I will be teaching anatomy. I will be picking up some topics from anatomy, and he will be integrating it with the surgery. We shall also do the MCQs. We will have a super solid class, guys. You will really fall in love with that class. Okay. And again, for all of those who are preparing for December FMGE exam, we are planning to launch a series of live sessions. Okay. Live sessions will start from 10th of November. They are starting with my lecture, that is anatomy. Okay. I will teach you the entire anatomy. I will condense all the entire anatomy and have a complete rapid revision of anatomy. Okay. Clear? Tomorrow at what Indian time? Indian time it is at 7 o'clock. I mean 7 p.m. Indian Standard Time. Okay. So from 10th November, we will have a series of live lectures. The rapid revision sessions on all the subjects, almost all the subjects for your FMG. Okay. Right, guys. So let us come back to the topic now. come back. Time, everything will be mentioned on the channel and even on the Telegram, okay? But for tomorrow, it will be at 7 o'clock. My session is at 7 o'clock. So carpal tunnel, guys. Carpal tunnel. What is this carpal tunnel in the sense? For example, when I cut my wrist, okay, when I'm cutting down my wrist, I'll cut my wrist and I will show it to you. When I'm cutting my wrist and when I'm showing to you, you can see this part, okay? You can see this part of the wrist, isn't it? You can see only this part of the wrist, okay? So I'm cutting it and I'm putting up a picture here. So what will be the outermost layer? The outermost layer will be skin. So this is the outermost layer. Next important thing is that you have got your bones. On the radial side, what bone do I have? Scaphoid, right? So here I have got a bone like this. This is called scaphoid. And here I have got another bone like this, lunate. And this is another bone, triquetrum. And another bone that is pisiform. Just above this, a Telegram link will be posted in the comment section, guys. Comment section, don't worry. Just above this, we have got another group. What are those another group? Look here. Trapezium, trapezoid, capitate, and hamate. So these are the carpal bones. So when you cut down the wrist, you will have carpal bones first, right? Above the carpal bones, I can find a lot of empty space here, isn't it? I can find a lot of empty space. So within this empty space, there is a small nerve here. This nerve within this empty space is called as your median nerve. All of you concentrate here. This is called as your median nerve. Okay. Another important thing is that covering the median nerve, from the surface of the median nerve, you have got a ligament attaching from one end of the hamate bone all the way till the scaphoid bone like this. There is a ligament that is attached. Now this ligament is transverse in nature. So I call it as transverse. It is passing over the carpal ligament. Transverse carpal ligament. This is called transverse carpal ligament. Okay. Now this is what is called as carpal tunnel. This is carpal tunnel. Now they will ask you, what are the borders of carpal tunnel? Anteriorly, I have got transverse carpal ligament. Anteriorly, I have got transverse carpal ligament. Posteriorly, I have got carpals. Anteriorly, I have got transverse carpal ligament. Clear? Next important thing. They will ask you, what are the contents? The first content, all of you know, that is median nerve. Median nerve is the first content. Second important content is that all of you know that there are a lot of tendons I have discussed that are passing like this. For example, I have discussed a tendon called flexor digitorum superficialis. It has got 4 tendons that is passing like this. It passes actually through the carpal tunnel. Flexor digitorum superficialis. When I tell flexor digitorum superficialis, you should also know another one, flexor digitorum profundus. And second important thing, there is one more tendon that passes like this all the way, joins to the thumb. What is this? Flexor pollicis longus. So all these are the contents of carpal tunnel. So what will happen is that whenever this transverse carpal ligament becomes stiff, what will happen? It will compress all these structures within that. So what do I do? Patient will have very severe pain here. This is called carpal tunnel syndrome. What do I do is that I will cut down this transverse carpal ligament. When I cut down this, I am decompressing it. Right? So what will I do here? I am cutting down this transverse carpal ligament like this. I am cutting open it. And cutting and opening it, what will happen? All the structures, they will relax. This is called carpal tunnel. Okay. So I'll be waiting for you tomorrow at 7 p.m. session, guys. Thank you so much, all of you, for your patience to listen to my lectures. And once I just want to know that all of you understood all the things which I have taught today without any doubt, guys. Yeah. Leftover topics we can look at tomorrow, but all of you understood it. Yes. Thank you so much, everyone, guys. Thank you so much. Love you all. Love you all a lot. Thank you for listening to my lectures, and your support is really needed for me to, teach the lectures in this way with much more clarity and all. Right? Thank you so much. Have a great night.